really we have created an existential crisis here, right? In that we don't, and to bring up your point, we don't know how to deal with pain. We don't know how to deal with the spiritual pain that comes with the life that we have created and what is occurring with us now. And we actually don't know what we're trying to treat.
Mr. Dale.
It's copacetic.
Copacetic. All right, I was just saying, this is the first time I'm hearing you say that word on the podcast, but apparently you've said it before.
I've said it before.
So if you're listening to this, do you remember the last time Dale said the word copacetic, and in what context? Do you remember?
I have no idea.
But you've said it before.
I'm pretty sure I say that word a lot. Maybe I lied. Maybe I didn't say it. I'm pretty sure I said that on the podcast, though.
I heard it this for the first time this week from a client.
Either you're lying or I'm lying. One of the two.
Copacetic. So what does the word mean?
It's a pretty word.
What does it mean?
Okay. That's a great question. I think I use it. Either I use it inappropriately or so let's look it up. I'm pretty sure it means kosher or appropriate.
Yeah, I feel like it's a positive term.
It's a positive term to mean kosher or appropriate.
Excellent order.
Yeah.
It's copacetic.
Yeah.
Awesome.
It's kosher.
By the way, we're drinking Izzy's today. Yes. I think it's the first time we're drinking on set.
Yeah, we got to talk to them too.
Yeah, they're good.
Yeah.
Izzy's are good. Another word that people use a lot.
Yeah.
But we often misuse it. But I think therapists use it correctly because of the context in which we use is ambivalent.
Oh yeah.
Have you heard people use the word ambivalent? Like in the way that it doesn't mean?
That's a good question. I honestly don't hear people use it outside of the therapy context that often.
Okay, so I do. And usually they'll be like, okay, I'm like, so what do you want to eat today? Where do you want to go eat? I'm ambivalent. Like, it doesn't matter. I'm ambivalent.
No, that's not correct.
Dude, some of the smartest people I know, including my wife, and she's an English teacher, so I always get her on this. This is like the one word.
That's the one word you can say.
She doesn't I'm like,
it doesn't
I got
mean
you,
that.
honey. Yeah, that's not what it means. And she was like, dude, that's what it means. We looked it up, and I'm like, nope.
Fact check.
Ambivalent. So we think ambivalent means like, oh, I don't care. I'm ambivalent, but it's almost really the opposite, right?
It's like I intentionally, I actively am not caring here.
Yeah.
Like there is actually an action towards that inaction.
Yeah.
Or at least what is the dictionary term for it?
For ambivalent?
Yeah.
Yeah. So the word ambivalent means having mixed feelings or contradictory ideas about something or someone. So I
use it inappropriately too. Then
because
I feel
this is so interesting.
Yeah, so
go ahead.
Well, no, I was just gonna say like the context that I use it in, and I hear it used in most is recovery talk.
Right.
Yeah. So talking about our ambivalence. Addiction talk.
Yeah.
And so typically when people use that, it's in notion to say like, okay, there's a high level of ambivalence, and it's like, yeah, I know what I need to do, but I'm not going to do it.
Yeah.
Right.
Okay, I get that context.
And so I guess in the sense, yes, there's still mixed here.
Like you're on the fence.
Yes, but there's a specific like an awareness towards I'm still in this place. And to some degree I'm okay with that, right? But there's this level of saying like, okay, I'm here. That's how that's either how I've used it, right? Mm-hmm. Or it's like active indifference. That's
active indifference.
Yes, that's the way that. And when I first even heard it,
yeah. Okay, that it makes sense. And I've also heard it used in the sense of like there is what's the opposite of indifference? There is care, but one doesn't know which way to go. Like they're ambivalent. They're on the fence.
I haven't heard it used that way before.
Yeah.
I've never, like, if someone was to use it with me, it would be like, you're ambivalent. Like, wait a second. No.
Yeah.
Because, well, I think, I guess in some ways I didn't use it inappropriately because mixed feelings means that there could be feelings of a desire to do something one way.
Yeah.
But also conscientiously saying, okay, I feel that I'm going to do this way. Right. So in some senses, I wasn't completely wrong.
Yeah.
But
okay.
Yeah.
So how about we talk about something today that a lot of us tend to have ambivalence over.
Ooh.
And it's something you brought up in our ADHD episode.
Okay.
When we were talking about methyl blue.
Yeah.
In particular, and
the reason my teeth are blue.
Yeah, right. Yeah, the reason why Dale's teeth are blue in today's episode. And one of the things I brought up was people may have issues with the idea of taking a synthetic substance or a synthetic drug to alleviate maybe some challenges that they deal with, whether it's ADHD or something else. And you said something very interesting.
Okay, what did I say?
You're like,
I don't even remember what I said.
Yeah, you're like, yes, it's synthetic, but you took a step back and you're like, everything is a medication. The way you view things, it's not just it's not that the synthetic thing is a medication. Like everything is a medication, and that's an interesting take. Could you? So I want to explore that further.
Sure.
What do you mean by everything is a medication? Like, how do you define the word medication? And how did you even come to that belief?
I'm curious.
Yeah.
I want to hear what Dr. Google has to say is what is it? Let's ask Dr. Google, what is a medication?
Okay.
We'll see how heavily I disagree with Google.
Google. A substance used for medical treatment. Okay, that's not a very good. Come on, Google. I'm so disappointed. How about ChatGPT? What is a medication? Don't use the word medical in it. Okay. Maybe I'm cheating there. Okay. A substance used to diagnose, treat, or prevent disease or to relieve symptoms. Okay. I think that's a better definition.
A substance used to diagnose or treat.
Yeah.
Oh, that's still very broad.
Okay.
Right. So I would say, in essence, I actually agree with Google and ChatGPT.
You do?
Yeah.
Okay.
Because if you think about that, okay, so the one difference I said here, they're saying a substance. I kind of look at that more broadly. I think anything, and so I guess how I view a medication is a treatment, right? And so really a medication is a treatment. And yeah, no, I'm at the end of the day, I think that's true. Like, okay, so something you're taking, you're putting in your body to either treat, alleviate, remedy. In most cases, though, I would say that seldom does anything treat or cure. I should say cure, not
cure.
Yeah. But a lot of times when people hear the word "this is treatment," they think it's a cure.
Yes, and even with meds.
Oh, especially with
this
meds.
Is a cure.
Yeah.
Okay.
Yeah.
So, okay. Well, I guess also, first off, like we're talking about medication, but we're not doctors, right?
Oh yeah, 100%. None of this is medical advice, and this is armchair opinion.
Armchair opinions, right? But as therapists, we do deal with a lot of
people on a lot of
medication
all the
and
time.
That is a very significant aspect of our assessment of our treatment plan.
It's so frustrating.
Tell me more about that.
It's so frustrating.
It's so frustrating
Sometimes, like, because you'll have people that come in on one medication, they'll get started on a new medication, and you notice things like, especially if you're seeing them weekly, right, or sometimes a couple times a week, you'll notice things start to go a different direction than when you first started seeing them. Maybe their symptoms, right, for what you're treating them for, start to worsen, or things start to look a little bit different here. How they're viewing things, their problem solving skills, their cognition, right? Things start to change.
Yeah.
And so if you have a good collaborative relationship with the prescribing provider, then a lot of times it's fairly easy. You can say, hey, just thought you should be aware of these changes that we're noticing here. If it's a good relationship, they'll say, oh, thank you. I appreciate that.
And if not?
If not, they either won't say anything.
Don't tell me what to do.
They'll tell you to try some more deep breathing with them or mindfulness.
The medication stays.
Yeah, it must be what you're doing. It's not the medication.
It's not the meds.
It's like, great. Okay.
Great. Yeah. Right.
It's definitely because mindfulness produces anxiety attacks.
Yeah. No, that's interesting. So what you're pointing out is something that, I learned quickly in my, even in my internship.
Sure.
Is that therapists, because we see clients on a weekly basis typically, or bi-weekly sometimes.
Sure.
We're seeing clients way more than your typical prescribing provider who maybe see a client maybe once a month for 20 minutes.
Once every few months. 15 minutes. It's like, okay, how's it going with this dosage? Yeah. Should we increase it? Should we decrease it? Should we change the meds? It's 10 to 15 minutes tops, usually.
Yeah, right. So because we're seeing these clients more often, we're seeing the impacts, the effects of different substances they're on, behaviors they're particular choices they're making. And so with meds, you do see that. And so even with therapists are often given the responsibility of helping clients with medication management.
Sure.
Because again, we're interacting with the clients more, and it's just like, okay, are you taking your meds? Are you?
Sure. It's in a majority of our treatment plans. If you were to look up any specific pre-written treatment plan, be helping the client be able to adhere to medication management, taking their medications on time. Yeah, so
because that's a psychological thing too.
It is, but which way are you thinking about that?
So the idea of it's one thing to know that I need to take meds. It's another thing to know how to make sure I do it consistently.
Sure.
And with, right?
Yeah.
And that's a whole other thing, right?
Yeah, this is a big topic.
A lot of soft spots.
Oh, yes. David can attest to the fact that I've gone on many a tirade about this topic. Only because, so here's some fun facts. So I just looked this up here because as we're talking about this, and I was using my ADHD powers. So, so interestingly, according to the CDC, for what that's worth, 49.9% of people used at least one prescription medication in the last 30 days. 24% are using at least 3 or more. And 13% are using at least 5 or more. And those are ones that are reported. Keep in mind, these are ones that are reported. So if you weren't called by the CDC or the NCHS data query system,
you're not accounted for.
You're not accounted for. And keep in mind, these aren't including self-prescriptions.
Yeah.
Right. So if we're calling a medication, so let's just clear the table for a second. If we're calling a medication a substance that you put in your body to help alleviate, treat symptoms, there's a lot on the table there, guys.
Beyond what your doctor gives.
Yeah, beyond what your doctor. I mean, the most popular, most common, absolutely marijuana and alcohol. Nicotine, excuse me.
So we don't typically classify those as medications.
We don't. No, but they are.
General speaking.
Yeah.
But they are.
100% they are. Because why do people drink alcohol?
Yeah.
For the buzz.
Yeah, to feel better.
To feel better. to be able to have, like, I mean, even if you're not alcoholic, how popular is near beer? And it's certainly becoming more popular now, right? Like, I can make a really great mocktail.
Yeah.
David can attest to.
Yes.
Like, excellent mocktail.
Oh yeah,
it's so good. I'll give out the recipe sometime. However,
trade secret.
Yeah. The reality is, though, people drink alcohol because of the feeling. They drink
100%.
alcohol because of the alcohol. That's why. Otherwise, you wouldn't drink alcohol. But with marijuana, yeah, same thing, right? Nicotine, same thing. Like, they don't have near cigarettes.
Well, the ones they've tried.
Yeah, they have tried. I mean, it's just
the closest is vaping, which also,
Again, it's the same thing. Like, now we have popcorn lung. Great.
Yes, exactly.
Which, if you haven't looked that up, just don't.
Oh,
right. No, but I think so we said some statistics here, right? These percentage of people. So again, to clarify, the one that's pretty like, whoa, like, it's 24% of people on 3 or more prescription drugs in the last 30 days that we know of. So if people are taking some other things on the side, most people with their medication, they're still going to drink alcohol or smoke marijuana or cigarettes. Like, that's, you could bet on that. Like, really quickly, look up the percentage of people that smoke
weed,
just in general, like
or to smoke.
Yeah, or cigarettes.
Okay.
Or use nicotine.
Yeah. What percentage? What's the statistics on percentage of people that use nicotine, and also give me the statistics on people that use marijuana?
Sure.
Come on, Chat GPT.
We'll see how
come through. All right, cigarette smoking. 11% of U.S. adults.
That's way lower than I thought it was.
Smoking cigarettes in the past week.
Oh, in the past week. Okay. Nice. Okay. Yeah.
Come on. What about vaping? Okay, marijuana use 15%.
That's not surprising with the
that's higher now.
Yeah, 15%. Okay.
Yeah?
Yeah.
I'm curious about vaping.
Let's look up alcohol for a second. We'll just get this one out of the way.
Yeah, alcohol?
Yeah.
All right, I did ask about alcohol. So here we have, all right, ChatGPT is producing some graphs for me. 6.5% vape. Majority of those are 21 to 24 years old. 6.5% use vape.
Okay.
And 51.6% of U.S. adults reported drinking alcohol in the past month.
Nice.
23.5% binge drinking.
Nice. Okay.
6% heavy alcohol.
So we've got like 20% of people binge drinking, at least 50% drinking all the time. So that's a medication like everybody's taking already. Mm-hmm. And then you already know, okay, so 15% are like using nicotine approximately, right? Mm-hmm. So then it's probably safe to say that somewhere in your 50% of people that are drinking alcohol are also using nicotine. Mm-hmm. And so if we look at that and we say, okay, well, 24.7% of people are using 3 or more prescription drugs in the last 30 days. Now we're up to 5. Right?
Yeah. So we're highly self-medicating.
Highly, right? Or we could just say highly medicated.
Highly medicating.
We're highly
whether it's
medicated.
prescribed, whether it's self.
We're highly medicated. You're approaching now, like, if you were to include those 2 variables, I think you're approaching now 50%. Mm-hmm. Like, if we included marijuana, alcohol, and nicotine, like, you'd probably be approaching 50%.
Yeah. And another interesting one is, how do you classify food?
Oh, well, yeah. Well, and then we also haven't even talked about, like, caffeine, right? Look up how many Americans, like, what's the percentage of Americans that drink caffeine?
Oh, man. Caffeine. All right. Let's go. And put a guess on it?
90.
Wow, that's high. And you were close, 85%.
Okay. I was, yeah.
Yeah.
Fair enough.
85%.
Okay, 85%. Okay, so, yeah, so if we include, so obviously we're not, but probably if you were to include that, okay, so now we're at least 50 people, or excuse me, 50, way more than 50 people. 50% of people medicating in some way, right?
Mm-hmm.
So I think, again, just on the onset, I'm not trying to say this because it's like, oh, this is all of a sudden bad, because I think my initial point, even in talking about ADHD, is like my biggest thing is, or rather my biggest question personally is, hey, does it help?
Does it help?
And if we measure help, how are we measuring help?
What is help?
I would say that help most effectively is going to be measured in the longitudinal viability of what it is you're taking, right? And the sustainability of what it is you're taking, and how well it actually treats and doesn't provide any negative impacts to your current lifestyle, right? If the risk is very low and the reward is high, great.
Right.
I would say that most of the medications that are included in this prescription drug use and then our self medications are not that way.
And it's also probably why most doctors wouldn't prescribe the self medications that we have, but there's also issues where some of these medications are so accepted that it's not like a doctor's going to tell you to get off it. If
they might tell you, hey, this isn't helping, or really try not to do this. Like, but it's not until you have cirrhosis that they're like, hey, this is going to kill you if you don't stop.
Yeah. Like a big one is I'm noticing so like one of the statistics I was surprised there was like weed. Marijuana is much higher than like smoking cigarettes and vaping. And I'm noticing a trend amongst like middle-aged women where marijuana there's an uptick, and it's almost like it's like replacing your glass of red wine. And I think a lot of it is because of this huge increase in social acceptability of marijuana in recent years. Yeah. Right. So it's like, just like if you're anxious,
smoke a little weed.
Yeah.
Pop a vape.
Yeah. Exactly.
Eat an edible.
There you go.
Which it's so funny because,
and we're not. And this is not even like, this is like THC. We're not even talking about like CBD.
Sure. Yeah.
We're talking like THC level.
And again, I'm certainly not here. I definitely have known folks that like, hey, they take it recreationally and they report that it helps them and it helps them function. I'm not here to knock that. It definitely, like the research would indicate that it does act as an anti-inflammatory, and there's some benefits there. Like, and also that the excuse me, I'm butchering that word, endocannabinoid system in your body is like evidently super old. Okay. Not going to try to take away all the validity there, but I think a lot of times when we get something new and shiny, like
psychedelics as well, we haven't even gone into that.
Well, because the reality is that like marijuana is a class of a hallucinogen. And let's see what class of drug is marijuana. Look it up.
Oh yeah.
I want to know what Google says. I'm curious.
What class of drug is it?
Yeah.
It's classified as... it's classified differently depending on the context. Okay, psychoactive drug, psychotropic, hallucinogen. Yep.
Yeah.
It is a depressant, stimulant, and hallucinogen. Mixed effects.
Great.
Whoa. Sedation, euphoria, and increased heart rate, and distortion of time and perception.
Yeah, so you think all the ideas you have are just great ones. And again, I want to be careful here, but the reality is that most often, I remember the first thing I remember hearing from people that were trying to get off is that they were like, I don't understand. Like, if they were taking that medication and they started noticing negative effects, one of the ones we don't notice with that particular one is that it can actually cause heightened anxiety, because it would have what we would classify like a paradoxical effect, in that it really, really decreases our I shouldn't say inhibitions. Alcohol does that more so, but rather our stress level, right? So just to say layman's terms, all right, we feel really relaxed. Typically, as soon as we hop off of that, though, like that anxiety spikes big, right? And obviously, we see there with what Dr. Google just said about, okay, yeah, like here's some things that it can also do.
Yeah.
There was one study I read, I wish I could find it now. Typically, the therapeutic dose ranges that they utilize to look at the efficacy of anti-inflammatory and decreasing anxiety stayed around like 12 milligrams, right? So it's not actually that much, comparatively speaking.
Like, is that enough to get you high?
Yeah.
Okay.
Yeah. So here's the thing. It depends on the person and tolerability.
Oh, yeah, true.
Right?
Yeah.
So for some people, they're going to get blasted. For other people that, are daily users, it's going to be like, what is this? Right? So again, I think circling back to this, I think a lot of this just is, okay, how long can we use this sustainably without any negative impacts to what we're doing and how we're trying to live our life? And some people, hey, it's their entire lives and that's good. Right? For a lot of other folks, though, it doesn't work that way. But that's not just that one.
And that's a good point there, is that just because something is permissible to all, right? Like, oh, this is something everyone can take. The benefits and the might vary based on individual. And that's even like the basis behind why a lot of medications are prescribed, because the idea is that the professional will assess your individual needs and give you the right dosage, give you the right medication. It's like, okay, this ADHD medicine is working for this person, but for you, we're going to give you this medication. We're going to start with this dosage based on your needs and your, right? So there's a lot of individualization that comes into play. And again, going back to something else you said earlier, is it helpful in the long term for you? Because even though it might not be something that's prescribed and it's something that's socially acceptable, just because it's permissible, is it actually benefiting you in the long term and like also holistically, right? Because we could talk about like how it's like, oh yeah, in this area it's helping my functioning, but are we looking at the overarching like data? What does the research say? What is like it say about like this medication's effect on health and wellness? Like, are we looking at the full scope of what the prognosis is of this medication?
Yeah, here's going to be a really interesting thing. Look, why don't you Google, and I'm not trying to steer you off this, but I think in the spirit of what you're saying, I think here's a big reason why we don't ask these questions as frequently. And this isn't going to be like surprising to anyone per se, but let's just out of curiosity look up how much money did pharmaceutical industries make last year?
How much money did the pharmaceutical industry
let's
make last year?
Yeah, let's just say one. Let's look at, say, Pfizer.
Okay, yeah. How much
or
money
Merck.
Yeah,
right?
How much money did
Merck is local to us.
Merck or Pfizer make last year? And also if you can do like a quick comparison to like other industries or firms, because some people might hear like 5 billion.
Yeah, and it's not.
Be like, okay, what does that mean?
Exactly.
It's it's a lot. This is hitting the spot.
That's good, huh?
All right. 63.6 billion for Pfizer 2024 and 64.2 billion for Merck. Come on, Merck. They 1 billion more than Pfizer. That's a significant there.
So say that number again.
63.6 billion for Pfizer. Notable contributions from COVID vaccine, right?
Is that what they said?
Yeah. And then Merck, cancer, immunotherapy, HIV vaccine, diabetes medication. Okay, so yeah, this is big, right? Because they make up the same amount as big tech. Estimated global revenue is 1.6 trillion for pharmaceuticals and 1.5 trillion for big tech. That's wild.
It is
because big tech.
Yeah.
I mean, the richest people are in big tech.
Yeah.
Elon Musk, Jeff Bezos,
Yeah.
Mark Zuckerberg,
Yeah.
big tech.
Big tech is comprehensive, right? It's like you're including rockets, computers.
Yeah, we're talking Meta.
Yeah,
we're talking that's tech.
Yeah.
And pharmaceuticals is like, yeah, dude. Yeah, we're eye to eye, man.
Yeah, so
that's wild.
Right there, and I think for most people, they're like, okay. Now, granted,
big tech is also, and we could argue that is a medication as well.
Yeah, totally, right? We haven't talked about your iPhone, right?
Mm-hmm.
So it's interesting here though, because that's a lot of money.
Yeah,
like that's a lot of money. So it's safe to say, all right, there is money in drugs, right? But hey, we've known about this for a long time. But there's money in drugs, safe to say. So here's the thing though, right? So obviously we know those companies still make, all right, like immunotherapies, those aren't cheap. Chemotherapies, those aren't cheap, right? Like, and let's also recognize too that many Americans are on medications for diabetes, right? Like that's extremely common, high blood pressure, hypertension, so like these things are extremely common. However, right, I wonder if it would be able to differentiate. I don't know that it could though.
Mm-hmm.
Again, that's still a lot of money, especially given that like many of those things like cancer and diabetes. Now, I certainly don't want to say all, but we do know that lifestyle heavily is dependent, especially on type 2 diabetes.
Yeah.
Right.
Like, yeah, it's reversible.
Exactly.
Based on lifestyle.
Yeah. Now, granted, you got to be careful too, because at some point it can get to the point to where it's going to be much harder to reverse.
Yeah.
Now, again, I don't want to
get in there.
Yeah. I don't want to get in the weeds. I'm not a doctor, especially for those dealing with diabetes. But having said that though, I'm curious here. Let's ask it. I wonder if it could get the statistic. How much money was made off of psychotropic medications?
Specifically?
Yes.
How much money was made off of psychotropic medications last year?
Yeah.
That's your, okay. Interesting. Curious. And could you define for the audience?
So basically I'm curious to know like,
and what is a psychotropic?
Yeah, so basically we're looking at or here, let's make it even more broad. Because this would probably be interesting. How much money was made off of SSRI medications last year?
Okay. So when you say psychotropic, you mean like medications?
So that was one class. So psychotropics are one class. SSRIs are antidepressants.
Yeah.
Right. This would be another class.
So what's psychotropic mean for people who don't know?
Yeah. So basically, typically these are medications that are helping manage more severe disorders like bipolar, schizophrenia, and severe mental health disorders. Right there, that's a specific class. SSRIs are typically medications that are used for anxiety, depression. Right, those are the most frequent. So I'm curious to know though, like even if we looked at one class of mental health, right, we're not even looking at ADHD. So we're looking at, hey, it's just anxiety, depression. Anxiety was the most frequently diagnosed disorder last year.
Well,
and will probably continue to stay for a little while until we can all get rid of our phones, which will never happen. But what's it say about SSRIs, for example?
So psychotropics in general was $21 billion.
21 billion
last year. SSRIs was 18 billion.
18 billion. All right.
Yeah.
Nice.
Crazy. Yep.
21 billion, 18 billion.
Yeah, that's a lot of money.
Nice.
A lot of money.
So 38 billion on just those two classes. Now let's look at stimulants.
Oh, stimulant?
Yeah, because that's technically speaking.
Could be more. A lot of money, guys, on drugs.
So what's it say?
Trying to feel better. Okay. 27 billion.
Yeah. Yep. So there we go. There we have it.
There you go. That's a lot.
Yeah.
That's a lot.
Yeah, so 56 billion.
Yeah,
55 billion. Excuse me.
That's huge.
Yeah. So we said the total was 200 some, right? What was the?
Well, the first in the
Yeah,
pharmaceutical,
yeah.
it was trillion.
It was in the trillions. Excuse me. Yeah.
Yeah.
But but that's no small number though. 55 billion.
Yeah. Oh, yeah, that's huge.
Yeah.
That's huge.
But now also we haven't even included like MAOI inhibitors. Right?
Yeah.
Another class.
Another class of
Yeah. So like we haven't included benzodiazepines. Like right? Okay. So like another class. Right? We haven't included anxiolytics. Right? That could take now some of these can cross reference into different classes. So there could be some overlap there. So, but it's probably safe to say you're looking at least 55 billion. Let's now compare this number with, hey, how much money was made in the alcohol industry last year? I would wager that.
How much money was made in the alcohol industry last year?
I would wager that it's way higher. I would hope it is.
You'd hope?
I would hope so.
That the alcohol companies
are
competing with the pharmaceutical companies? Let's see. Okay. 1.76 trillion.
That sounds right. Okay.
So it's a close. Yeah.
1.76 trillion. But how much was?
And it was 1.6 trillion for pharmaceuticals.
It was 1.6 trillion for okay.
So it's higher. Than pharmaceuticals.
It's higher than pharmaceuticals. Okay. Yeah.
Oh.
That's a big industry.
That's a big industry. So that's like, again, that's medication there.
Exactly. So I don't know.
So what do these numbers mean to you when you?
So the way that I think about that is it's just there's a lot of money within those industries, but I think it's also helpful to know that because to some degree, like in my opinion, having the alcohol number higher feels a little bit better than if it was to be lower. That would be a little bit scary. Now, granted, the number that it's at now, I mean, 55 billion, like that's still a big industry.
Massive.
Yeah. It's still a big industry. And granted, those are protected substances. So that will also throw things into a frame of reference. Alcohol, anyone can get anywhere. So it's highly accessible. We're making something like a protected agent that you have to go see someone for. It's actually in some ways highly inconvenient to get, but it's still grossing.
Yeah.
$55 billion.
You gotta go to ABC. You gotta
exactly like you have so many. So it's interesting here, like also to look at hospital emergency department visits, right? Patient percent of visits involving drug therapy, 76.2%. Right. In other words, like. Something like, and what I'd be curious to know about this is like, I don't know if this is actually included, because if drugs are used in that sense, in that setting, like obviously a doctor is prescribing and then utilizing that. But I'm curious to know like whether or not the data for like the pharmaceutical industry, like is utilized in the same fashion because hospitals also have their own pharmacies. Right.
Yeah.
And so like you could argue that there's also a huge part of this that's not included in your data sample.
Yeah.
Right.
Yeah.
So that would be interesting too. Now,
man. Yeah.
Yeah. Lots of stuff here. Lots of numbers.
Highly medicated.
Yeah. It's safe to say like,
and I think
moral of the story, highly medicated.
Yeah. And coming from Kenya, I'd say that probably way more medication happening in the US in the West than in other countries. Not to say, well, maybe alcohol we're maybe on par. Let's put it. Let me not go there.
I don't think so. No way. Huh? No way. You think Kenyans?
Kenyans drink. But Kenyans are known around the world.
Is the alcohol industry?
Kenyans are known around the world.
Is it as big as in the States?
Well, obviously not because of like we could look at it per capita or right. Okay. Also like what type of alcohol are people buying. Like,
yeah, you can make
people
bamboo
buy like
juice.
the local,
Yeah.
the local brew.
Yeah.
But people drink.
Yeah, I totally
in
believe you.
Kenya.
I totally believe you.
And it's also like the individual. They're individuals who drink for their village themselves. You know what I'm saying? Yeah. So it's like Kenyans are known.
Sobriety is chasing them, but they are faster.
Yeah, exactly. Sobriety cannot catch them.
That's so funny.
So yeah, but in general, I'd say America's more of a medicated society. And I would be surprised if it wasn't linked to the fact that Americans, and let me not say Americans, but the West has a more difficult time managing and dealing with pain than other cultures. And the anthropological studies have been done on this.
Yeah.
That the West has the hardest time dealing with pain.
We don't like discomfort.
Yeah. And so what happens when you feel bad? You want to feel good. What are you going to do? Pop a drug, smoke a joint, prescribe, right?
Yeah.
So I'm sure there's very direct correlation there. Even causation at some point. I was like, okay, why are we taking all these meds? Because we're in pain.
Yeah.
We want to feel better.
Yeah.
Yeah.
I 100% agree.
Some of the meds help, right? Like you said, but to what extent? And then something else you said as well that is pretty significant is that meds treat symptoms, but there's a difference between treating symptoms and curing.
100%.
There's a difference between treating symptoms and going to the root cause. There's a difference between treating symptoms and working on preventing symptoms from existing in the first place, or just being able to maybe reduce the occurrence of symptoms occurring, right? So and that involves much more, I'd say, much more labor. Let's put it that way. Because the medication is like, you need the money, you need to be able to afford it. You can just pop the pill, and it changes you, right? Versus like behavior change, or versus like, let's look at the root causes. Like, what is this? What can we change, or what can we adjust here to be at a place where this medication maybe wouldn't even be necessary, or it maybe would be something I take on occasion basis. Like, even when we talked about ADHD, like, there's some occasions where it's like, okay, today I need this. I need this meds because I was listening to funny enough recently. So Trevor Noah has a podcast, the comedian.
Okay.
And he has ADHD, and he invited his clinical psychologist to talk about ADHD.
Nice.
It was a very interesting episode, and he talked about how he doesn't typically take medication, but when he travels to like a new place, like whether you're on vacation, when he arrives, that disruption of routine messes up mentally, and so he takes medication for those times. So there's like extenuating circumstances where it's like, in this circumstance, medication. But is it necessary in all circumstances? Right? Again, my thing is like, I'm not anti-medication. I'm anti. I am, as a Kenyan in the West, first of all, like I definitely have a more critical eye towards how medications are used in the U.S. And fair one could say like, dude, but what are the survival rates? Like, are people living more here or not?
I don't know that that's even necessarily as relevant as quality of life. Right.
There you go.
Imagine if you did a survey around life fulfillment in a country right?
I think they've done this like happiness studies.
Yeah,
or
well, they
whatever.
call them happiness. I think that's crap, though.
Yeah,
Like,
that's
I hate that
another
word.
episode. That's for another
Yeah.
episode. Yeah.
So, but no, I think it's relevant too, because if you look at our country in terms of rates of suicide,
Oh yeah, way higher.
right now there are some countries. So we may still be at the top. I'm not sure. So look up rates of countries with the highest rates of suicide.
Yeah, give me a list of the countries with the highest rates of suicide. Yeah, that's good. That's a good question. That's a good question. So here,
I think there was some European countries might have beaten us, but it also depends if we're talking per capita or if we're talking actual numbers.
Interesting. America's not even on the top 10.
Yeah, where are we? Where are we? We're at.
Well, it showed me the top 10, and America's not on there. Well,
is it
funnily
rated?
enough, Lesotho, which is a small country in Southern Africa, is
wait,
the
but
highest,
how is this
apparently.
data taken? I'm wondering,
Yeah,
because that
that's
can't
what
be
I'm like.
right.
I'm like,
Lesotho doesn't even have a population
per 100,000 people. Number per 100,000 people.
Okay.
Yeah. So here, the United States is 14.7 per 100,000 people.
Okay.
And Lesotho is 87.5 per 100,000 people, which is the highest.
How many people are in Lesotho, though?
Oh, very few, like 100,000.
I mean, like,
I'm kidding, right?
Okay.
Yeah.
Like,
exactly. That's so. It's
numbers can lie, guys.
Numbers can lie, but apparently within developed countries, South Korea is the highest, 24
per
100,000
Okay.
people, which makes sense.
That does actually make sense. That does track. So what other countries? So South Korea, Japan. All right.
Well, Japan is actually on par with the States.
Okay, so
but
what?
It's South Korea, Lithuania, Hungary, Slovenia, Japan, U.S.
Okay.
Belgium, Finland, France, Austria.
And Lesotho, I wonder. That's interesting how that beat us out. That has to be a numbers game there.
Yeah, we need to like have an episode on suicide, maybe.
Yeah, we totally should. But I would say that there's.
So yeah, why did you?
Well, so I was curious about that because, again, if essentially, I believe that there's a correlation between, and correlation doesn't equal causation, right? But I think in this context, such a high correlation is worth understanding better. But I would believe that there's a strong correlation between how distracted we desire to be and our inability to be able to deal with pain and discomfort, and then the propensity to be able to view life in such a fashion and then have it be problematic. Right. And then obviously we're talking about things like suicide as well. So typically if we're saying like, okay, if we're trying to measure a high degree of unhappiness, well, okay, or fulfillment, it doesn't really get any greater than someone saying, all right, well, I'm going to disappear from this life now.
Yeah.
Right. And so in some ways you would expect that if you're high up there on that list, you would also be high up there on prescriptions.
Yeah.
So here, let's do another thing. This might be curious. Countries with the highest prescription rates.
Yeah, that's good. And you know what's even interesting on the suicide part is like it's interesting to see high numbers in developed countries. Because again, like what is the cause? Like what is it? Is it because like so in Lesotho people dying by suicide because they cannot afford certain basic necessities? Right? Would the rate remain higher all things kept constant? Right? Considered. But you said countries with highest prescriptions.
Or per capita.
Per capita. Yeah. Today's a ChatGPT statistics episode.
Yeah, because
oh man. So funny. So good. All right. No, not states, countries. It's giving me states in the US.
That might be interesting too, but I'm not interested in that right now.
Yeah. Countries with the highest prescribing. Okay. Let's go. All right. So we have a ranking here. Man, ChatGPT is giving me way more than I asked it for.
Oh man,
I'm like, dude, I just want to know.
it's listening to our episode.
Yeah, it's crazy. In the U.S., per capita spending on prescribed medicine was $1,126, significantly higher than the average of $552. So it's like double comparable countries. Double.
And where's South Korea and Japan?
They don't even show up. Japan is $752.
Okay.
Mm-hmm. So one could also argue that we pay more for meds, but
yeah,
still we're the highest by far.
That's interesting.
U.S. is the highest by far.
That's interesting though, because I wonder then how much other pharmaceutical companies make in other countries.
Right.
So that might be interesting to know
too. Yeah. So okay. So again, like, I'm curious, what's the
angle?
The angle.
Yeah, the angle for me, I'm just interested to know how much, and I think this is the question here, right? How much is our pharmaceutical industry actually driven by profit? Right? And can that show up in the numbers? Right? Comparatively to other countries, which is where I think that's interesting to do some digging there. And typically, I would argue
$625 billion, largest pharma market globally. 40% of global drug sales is the U.S. 40%.
Yeah. So there's money.
We're just a very small population.
Yeah.
400 million.
Yeah.
China is 170 billion. China.
Yeah. So
China has
basically,
China has like 5 times as many people, and it's like a fifth of the size.
Yeah. So basically, that data. So let's clarify that again. So it seems that the numbers there would actually demonstrate to us that no, there's money to be made in our pharmaceutical, and we're certainly not the first people to talk about this. Big pharma came up in conversations long ago, right? But it's interesting to look at these numbers and say, oh yeah, no, this is pretty visible here. And those numbers are that way for a reason.
Yeah.
Supply and demand. But then beyond that, we can see that, okay, other countries still deal with other things, right? Suicide rates are high, presumably, right?
Yeah.
But
people struggle,
people perhaps utilize medications still, but yet the industry in those countries is not as high.
Yeah. Nowhere close.
So that tells us that, okay, medications may still be doled out, but the industry isn't as high, which means, okay, like there isn't a profit to be sought, right?
Yeah.
Or presumably at least as high.
Right. Like it's a culture. At some point, something becomes a culture.
Yeah.
It's like, this is the way things are, is that we medicate. That's what we do.
Yeah. And I would be interested to know too, like, because I think 100% and I think this is a human problem across the board, the more that we tend to distract, right, or indulge in distraction, the more we increase our propensity to edge towards an existential crisis.
That Viktor Frankl quote comes back to mind.
100%.
Right?
Yes.
When
man cannot find a deep sense of purpose, he distracts himself with pleasure.
Yeah. So what's funny is that, so the anthropological study I was referencing, I think he's called Richard Schwarzer. I need to confirm, but he basically, and guys, please go verify this. He basically studied different cultures in the world and how they manage pain, and it's like a peer-reviewed study. And he realized that the West was the poorest at managing pain, and the reason why, according to his research, was because the West had a very they lacked an ability to contextualize pain and to assign meaning.
100%.
to their pain.
100%.
And so what he found is that in these other cultures, what they do is a lot of their spirituality, their faith, the idea of like an afterlife, or like these things would contextualize the struggles and the different things in life that happen to them. And so they're able to overcome and get through the pain. Versus like, dude, in the West, we don't have anything. So that lack of meaning, that lack of contextualization leads to higher, there's higher prevalence of like pain, crisis.
Yeah. No, I think that's 100% relevant, and we definitely got to bring that up when we talk about PTSD at some point in trauma.
Okay.
Because that's highly relevant to that conversation. I don't want to get too far off.
Don't want to get too.
But it's highly relevant to that conversation.
Yeah.
So
interesting.
Yeah. In any case, so all in all, circling back to these points, I think talking about medication, I believe that everything is a medication. Honestly, I do. I think the bigger questions are, all right, like, does it help you sustainably long term? And is it something that the pros outweigh the cons pretty easily? There's not significant side effects, and long-term use isn't going to be detrimental to you. The trouble I have personally with a lot of prescription medications is that there's some that do have significant negative side effects from what we're doing, but then the expectation on quality of life is so low, right? When you have a very large percentage of your population dealing with diabetes, heart disease, comparatively to the rest of the world, or okay, like let's say you have 50% of them self-medicating, or excuse me, not self, but yes, self-medicating, because they're asking for these medications from a physician, right? There's that. I believe that should tell us that there's a problem with how we need to utilize something and the efficacy of something. And again, under the same guise, like, I think that ideally a medication would be able to help and ameliorate in such a way that it doesn't require or necessitate another medication.
So you'd be like medication stacking?
Yes. So for instance, something that's really common is, okay, somebody feels depressed, so they take a medication for depression. But then, all right, well, now it just affected my sex drive. I have no sex drive. So then they take something for their sex drive. But then they get anxious when they take that. Or perhaps like it creates some other problems. So now they have to alter this. Or for instance, somebody is feeling anxious, so they take a medication for anxiety, but then they feel depressed, or then they feel emotionless, right? And over a period of time, I would say that it's extremely common for people to notice side effects like these. Now, granted, again, I'm not trying to say that there's something wrong, like you shouldn't use a medication. Hey, if it works. But that's the key part. That's a key question. How do we define whether or not something works, right? Truly. Like just because you had symptom abatement for a few weeks, a few months, like, okay, great. Like the long-term sustainability, I would say, is overlooked in many cases, or rather, if it is looked at, it's not seen from a lens of actually a holistic lens of what is good for this person holistically. A case in point, we talked about this in relationship to ADHD medications. Like even in research that I've reviewed, okay, Adderall had one of the highest efficacies for being able to treat symptoms of ADHD, and there was little risks associated with even giving it to children in low doses. However, how many of them actually reviewed how many of our athletes were able to take this sustainably, say endurance athletes, and not have any issues?
Yeah.
The answer is very few.
Good question, yeah.
Because like it kills your overall endurance and your ability to, say, do your sport, perform at the same efficacy as you were before, right? Or
you get wiped when you're on your ADHD
if I took ADHD medication in the past, like my performance tanked as far as my physical endurance. Yeah. It was terrible. Right.
Oh.
And so,
very noticeable.
Oh, it's very noticeable.
Yeah.
And it's like, I've dealt with a lot of college students that report the same thing. Maybe they're collegiate athletes and they come in, they're like, oh yeah, I'm dealing with this. But then you take a stimulant, yeah, things, I mean, we can see it in, say, pre-workout stuff, right? Like if you're an endurance like, or if you're any type of wrestler or doing jiu-jitsu, it's like the last thing you want to do before you step on the mat is take pre-workout. Because you get an adrenaline dump like halfway through. If your match has to go like 5 to 10 minutes, that's a lot of energy exertion going out there that is just literally going to tank within the first 2 minutes. Now, hey, maybe if you're a power lifter, okay,
Right.
that might be appropriate.
For your endurance,
But
talking about endurance,
any type of endurance, like that's a problem, right? Or let's say, hey, if I'm significantly overweight, right? Or I have hypertension, right? And I have ADHD and I'm taking this for ADHD. Well, now I'm going to need to take something for blood pressure. If I wasn't before, I'm going to need to increase that, presumably, right? Because it's going to do the same thing to me that it did to somebody else as far as blood pressure is concerned.
Yep.
So there's a lot of really observable issues here, right? And then not to mention, there's still a very strong question as to, now I'm going to hop over to SSRIs. Johann Hari wrote a book. Now, again, I don't want to necessarily subscribe to all notions here, but I think he brought up a lot of really good points in his book, Lost Connections. And it reviewed, all right, like the percent, essentially it reviewed the data looking at the hypothesis for serotonin as a cause for depression. And I don't know if people are aware of this, but when drug companies try to get a drug passed, right, they can do a number of studies looking at placebo versus their drug effect. And they get to choose which study they utilize or publish. Now, you can find the other studies as far as that they perform, but they don't just do one and then say, all right, we're going to look at efficacy based on
this one.
Yeah. No, what they do is they choose the most favorable.
Obviously.
Obviously.
I mean, what would you do if
you're
a pharmaceutical?
And of course, you can understand. But what that means, though, is that there is a number of different studies that point to different outcomes, right? Such that there is still a strong argument to be had for serotonin not being solely responsible for depression.
Yeah.
Right? To the point that we still arguably don't know that serotonin causes depression.
Yeah.
Like there's an argument to be made to say, are you sure that a decrease in serotonin is what causes depression definitively? Like we can definitively say that beyond the shadow of a doubt. Now, many psychologists I know that I respect a lot, like say, oh yeah, no, they may bring up, there's these things here. Again, not to completely discredit that, but there's still a lot of information to support that we actually don't know.
We don't, yeah.
But
and
for
also the
years
evidence
now,
is also like, people are on these SSRIs and the symptoms are not being alleviated.
Exactly. And I would say that's the strongest evidence because in many cases, if you say, well, this SSRI didn't work for me, so I'm going to try this one because it does something slightly different, presumably, or this person responded to it well. The other problem is that if you look at a lot of these other studies too, one thing that you'll notice is that in certain cases, there wasn't a significant difference between the placebo and the drug itself. Now, we'd say, okay, there may be a small statistical difference. But again, some studies operate where it may be very difficult for an individual to not know what they're taking. And you need to have that. You need to make sure that you have effectively a double-blind scenario, right? A measure of making sure that the individual that you are utilizing in this research doesn't know whether they're getting placebo or doesn't know that they're getting a medication, or hopefully maybe they don't know at all what they're getting. Ideally, you'd say, all right, well, we're going to give you something. We're not going to tell you what it's used for. We just want to know what you notice in these areas of your life. Because if I anticipate to feel a certain thing from a certain medication, we have to be sure that, all right, what was it placebo or not? And again, this can happen with many things, but I would say the thing that we would want to look at is, all right, does this agent definitively do these things, and is this thing increasing associated with this symptom alleviation? So ergo, like, did it increase their serotonin, right? do we see that same alleviation associated with a decrease in depression and associated outcomes?
Right.
The problem is we don't always.
We don't, yeah.
And so for that reason, a lot of times what people end up what happens in many cases is, oh, well, maybe we had the diagnosis wrong. So maybe it did do the right thing, but we just they weren't diagnosed correctly. They don't really have depression. They have anxiety or they have ADHD, right? So we give them a stimulant and things get better. Well, of course they get better, because if you give the average person a stimulant, they're going to feel good. Now, they may feel highly anxious, so it may not be great. But again, a stimulant is going to quite literally. You. Yeah, exactly.
Oof. Yeah, that's messy. That just sounds messy, man.
It is messy.
Yeah.
So I guess, and again, in a perfect world, you try one thing, do your same life routine.
See what changes.
Every day. Like the same things every day. Institute one alteration. 30 days. See what happens. If you want to be really on it, do some blood work. See what your body demonstrates changing. Right? Because for most people, and I think you even brought this up, that Soren Kierkegaard had said, right? What was the quote that Soren Kierkegaard said about walking?
Oh, he's like, walking solves like all problems. Something like that. Yeah. Yeah. So, yeah. Above all, do not lose your desire to walk. Every day I walk myself into a state of well-being and walk away from every illness. I have walked myself into my best thoughts, and I know of no thought so burdensome that one cannot walk away from it.
But I think it's an interesting thing, because I think at the same time, like, simply moving your body, like exercise is huge. Like, again, brain-derived nootropic factor. We talked about that in the ADHD episode, and that's been well known, well researched for a long time. But again, you can hear people every day talk about how much their life has changed from instituting a simple routine adjustment with something like exercise. Like, you could get millions upon billions of reports for that. Right? One alteration here. Now, again, you have people do the same thing with a certain substance or drug, right? Well, the curiosity I would have is to really be able to measure efficacy, we have to be able to track something over time and ensure that the same things that you have in your life going on, like, have been able to remain consistent and reliable. And then we can actually be able to understand how something's impacting you. Because in most cases, I would say that, like, especially if we want to know if a substance is not helping us appropriately, typically it can't keep things consistent and reliable. Or rather, like, we are not able to stay consistent and reliable.
Yeah, that's how you know things are not.
Yeah. And I would say that's challenging, right? Nor do we want other things to become inconsistent and then unreliable. And I would say that a challenge that is greatly reported among many pharmaceuticals for, let's say, mental health areas, is that people have a harder time in certain moments connecting with a measure of emotional empathy and emotional awareness. So it can become challenging for them to be able to resonate with other people in moments of connection, right? So that's a common thing that I hear. Like, the common report might be, I just feel emotionless, which maybe in some cases can be helpful, because maybe I don't go off the rails and I'm not
feeling numb.
But feeling numb completely, well, that's dangerous.
Yeah.
Like, from a physical perspective, if I say leprosy, that's the common disease, right?
Oh yeah. If you feel numb.
Well, now I don't know if I cut my arm open.
Yeah.
Right. And that's a problem, because it gets infected and you could die. Right. So there is a certain degree, again, like I've said this before, like, it's not that emotions are bad. Right. It's the fact that, okay, we need to be able to not allow them to drive, but you have to know what it is that you are carrying.
Yeah.
Right? We need to know the present players. Being able to connect to that allows you to connect to other people. Right? Because then
Essential.
you can... Exactly. It's essential for connecting with other people. It's essential for me to be able to understand and resonate with what you may experience, because I've experienced that too. Because I'm feeling that as well. Right? I can sense that. That's a very human thing. It's essential to your existence. It's what makes music so powerful. And so if there's certain parts of things that are completely removing our ability to do this, well, it stands to reason that they may need to be evaluated. Now, perhaps, hey, yeah, if they're too high all the time or too all over the place all the time, okay, yeah, fair. But is that sustainable and reliable? Right.
And maybe that's then further supports the idea that in many cases, medications for people can be seen as a lifeboat.
100%.
In a very unreliable, sustainable maybe situation that then one can stabilize, or maybe at least get to a point where they can then either wean off the meds or like adopt other strategies that are more sustainable and reliable to be able to live functionally and live a good life, right? Because like a lifeboat, you're not going to use the lifeboat to cross the Atlantic, but you use your lifeboat if you're drowning, if you're shipwrecked. And sometimes the lifeboat, for some medications, and it's not even a lifeboat. It's not even a lifeboat for you. But what is it for you? What is that? What is this medication to you? This is the question, right?
Yeah, so I think there's the adage, and this could be phrased a lot of different ways, but one way to phrase it, and this is more common in recovery work, and that's that typically when abuse starts to happen around things, like you manage, say, medication abuse or drug abuse based on how unmanageable things are becoming, right? To what level of dysfunction is actually occurring, right? When it's, and that's really, it's a fine line. It's really blurry sometimes too, because you have plenty of functioning individuals,
functioning addicts,
right? That may still be abusing something or taking something way inordinately, right? But a common way to think about this is, or it's probably not common enough actually, right? It's a physical solution to a spiritual problem.
Right.
And when I say that, I mean that really we have created an existential crisis here, right? In that we don't, and to bring up your point, we don't know how to deal with pain. We don't know how to deal with the spiritual pain that comes with the life that we have created and what is occurring with us now. And we actually don't know what we're trying to treat. I think that's the biggest problem. And I would argue it's the biggest problem that many physicians alike have, in that they're shooting in the dark. They're like, hey, let's try this and just see if it helps, because we don't know.
Yeah.
Which is why, which
and
is
a
why
physician will never tell you this is a cure. Never.
No.
They can't.
No.
Then they'll be liable, right? Yeah. So it's like we don't know, but we have, okay, the evidence suggests this, or at least the evidence that we have, but we're gonna try.
Exactly.
See what happens.
So, case in point, hey, I think reliability, consistency, how well things are added to and not taken away from. And a basic way that I believe that's really functional to look at anything we're ingesting or putting into our body is, hey, is the reward really high if it works? And is the risk really low?
Yeah.
Really simple.
And I think a big part of evaluating that is being willing to receive feedback about that. Because 100%. Sometimes we can be super biased and be like, well, it is very rewarding in this way.
Yeah.
right? And maybe it might not even be that you might be taking one medication, self-medicating, when you actually, what you really need is prescribed medication.
Sure.
Like you need an expert. I need it to be like, look, listen, like you're dealing with this issue. There's actually meds that can help you that won't lead to these huge consequences, right? I think about, like, for example, like psychotic medication for psychotic disorders.
Sure.
It's like, listen, like maybe this medication might be much helpful than you taking this alcohol or marijuana for your particular issue.
High potency.
Right. So it's like, are you open to feedback?
Yeah.
Informed feedback.
Well, and so this is where too, I think most often the medications that are the most reliable are the ones, well, I need to be careful with this because there's definitely some very reliable medications that are extremely potent, right? To the effect that it's like 0.1 milligram. Like, so again, you have some very potent agents.
0.1 milligrams.
Oh, yeah. I mean, so again, and so there's some you have to be very careful with, but I would say that the ones, in most cases, I think any change that happens slowly over a period of time is going to be more reliable and safer.
Right.
Than something that happens drastically and quickly. Now, again, that's not always the case. Like hey, don't get me wrong. Like one of the more effective treatments for, say, acetaminophen overdose is NAC. Right. That's a supplement that you can get on Amazon. Right now, I believe they use it intravenously when they do that, but or like even so methylene blue, like I think it's hemoglobinemia, or like basically your body starts your oxygen. Yeah, you start losing oxygen in your body, and so like it helps increase hemoglobin and reoxygenates your blood effectively. I may have butchered how that looks, so forgive me, chemists. But it's a very quick active treatment, relatively speaking. However, that's also in a very high dose that you would utilize that for. So like, I think when all things considered, I think it's important. My personal biased opinion is, hey, low, slow, long-term impacts, low risk, high reward. And I think based on the amount of money that our country spends on this, or hey, let's just say globally, it's a human problem.
It's a human problem.
I think it's a big problem here
in the West, yeah. But
with that, it would indicate that it's not typically that way because people are impatient.
Yes. Well, I love how all roads led back to methylene blue. We started with methylene blue and we ended with it.
Oh my gosh. I'm clearly too biased.
It's the current.
It's the current shiny thing.
Yeah, it's the current shiny. Right? But hey, it's a good one. Yeah. Sounds like
not in high doses, and certainly not for everyone. Right. Absolutely talk to your doctor before trying to put anything in your body, please.
Amen.
But
and with that,
with
that non-medical
advice. It's not advice, just opinion.
Non-medical opinion.
Yeah.
With that, this was helpful. Yeah, some of those stats were very.
It's interesting.
Yeah, very, very alarming, and also very just interesting. Yeah, very fascinating.
Yeah, cool. Until next time.